So what I would like to talk about is brainstem cavernoma. I changed the title a little bit after I did some work on this talk the last few days. I realized it should better be titled Concepts, Strategies, and Technical Tips. My email is at the bottom of this slide. If any of the young people have questions after the talk, feel free to email me. I'll do my best to answer any questions you may have. I would like to start by thanking particularly 3 people, 2 of our spectacular residents at the University of Miami, at Jackson Memorial Hospital here in Miami, Kat Berry and Evan Luther, who helped me put some of the data of my cases together, and of course, my current fellow, Samir Sur, a cerebrovascular skull-based fellow, that also helped me with some of the videos. And of course, I'd like to thank every resident or fellow that I've trained over the last minute that have contributed to the care of some of the patients I will show today. So, what is the outline of my talk? Anatomy of the brainstem, both pure and surgical. Then I'm going to talk about surgical principles, and I'd like to divide it between goals, strategies, and tactics. Then I'll describe some surgical approaches. Then I will show a series of videos of case examples throughout the brainstem. Anatomy, pure anatomy. Well, this is the brainstem. There is always controversy. What is the brainstem? Does it include the diencephalon and so forth? It's not so important, but for the sake of today's talk, I'm going to consider the brainstem as midbrain, pons, and medulla. Naturally, I cannot go over the detailed anatomy of the brainstem. It will take us 3 hours just to do that. But to give a taste for, particularly for the younger people on the talk, on the conference today, think of it in 6 levels. If you divide the medulla into rostral and caudal, the pons into upper or middle and caudal, and midbrain into rostral and caudal. And let's just quickly see what lives in those sections of the brainstem. I'm going to start at the top and going down to the bottom. Obviously, I'm not going to name every structure. It is just too much. Just have a look what lives there. Rostral midbrain. You can read on the left what's there. Motor, then sensory system, then autonomic and other systems. And you can then see, this is a summary of the rostral midbrain, how busy the slide is with the different colors. Next, caudal midbrain. You can see what's there in the motor system. You can see what's there in the sensory system. Notice the medial and trigeminal lemnisci and the lateral lemniscus in orange up there for hearing. Then the autonomic and other system for the caudal midbrain. You put it all together, that's the caudal midbrain. Then the pons, then that's the mid and upper pons motor system. You can see the sensory system of the mid pons. You can see the autonomic and other system. And that's a summary of what lives in the mid pons. By the way, the pons, as you will see later, is the most common site for cavernous angiomas in the brainstem, is about 60%. Of course, it's because of its volume. Now we have the caudal pons, motor system, a lot. You can see there on the left that whole list. You can see the sensory system. You can see autonomic and other pathways in the caudal pons. And that is a summary of the caudal pons. Again, quite busy, except in the corticobulbar fibers that you can see crossing transversely. Otherwise, it's quite dense. And that's, of course, corticospinal. How about rostral medulla? You can recognize the olive. Some people say it looks like a butterfly. By the way, all of those sections, everybody has their favorite animal to make an analogy with the different sections. There is the motor system of the rostral medulla. There is a sensory system of the rostral medulla. autonomic and other system. And that's a summary of the rostral medulla, very busy place. You can see all the colors took the entire section. And lastly, the caudal medulla, very recognizable by the medullary pyramids and the decussation, and that's a sensory system, and that's the autonomic and other pathways of what lives in the brainstem. That's pure anatomy. We need to know that before we can move on to surgical anatomy. So where do I start here? Well, I have to start with Albino Briccolo, because Albino Briccolo in Italy many years ago started this concept, as he was mostly talking not about cavernomas, but about tumors of the brain stem, about trying to figure out what are the risky areas to enter and what are the so-called, and I hate this term and I will come back to that later, this business of safe entry zone can be very misleading, but you will see it in the literature that those are generally accepted as relatively safe to enter. For example, supracollicular, infracollicular. As I will show you later, this is midline sulcus here. A very safe one is the lateral mesencephalic sulcus. Then you've got the suprafacial triangle, and you've got the infrafacial triangle. And you've got the sulci in the medulla. I'll go over this section by section. I've colored in green what is probably safe in general. You will see why I'm trying to be vague, because it's not always true. So for the midbrain, anteriorly, you can go medial to the corticospinal tract. This is the anterior brain zone. Posteriorly, you can go between the colliculi or above or below them. And laterally, the lateral sulcus, mesencephalic sulcus. Those are kind of the three general areas. How about the pons? Now, the pons, I've put in green what is considered by most as safe, and that's supratrigeminal zone, peritrigeminal zone, and low zone. That's laterally. Posteriorly, I mentioned them already, suprafacial and infrafacial. I have put in orange those two areas because I am not convinced, certainly not this one between the MLF. I am not convinced at all this is a safe area to enter. And certainly there's been some case reports of endonasal endoscopic transclive approaches to some cavernomas of the pons, but that does not mean that the area of the basilar artery sulcus is a safe zone. Medulla, you can go through the olive or retroolivary sulcus in front of cranial nerve 9 and 10, and possibly between the medullary pyramids from anteriorly, and posteriorly, the posterior midline sulcus or the lateral medullary zone. And that's about it for the medulla. So putting it all together, the green arrows are areas you could consider enter the brainstem from. Midbrain, rostral caudal, pons, rostral caudal, medulla, rostral caudal. So anatomy isn't surgery. So then when you start talking about possible surgical approaches, and I'll get to those in a minute, you can lay down all the familiar approaches you may know. Transsylvian, terrinal, pretemporal, orbitozygomatic, subtemporal, infratentorial, supracerebellar, occipital, transtentorial. You can go presigmoid, transpetrous, the whole family of them, retrolab, partial translab, transcochlear. You can do retrosigmoid, you can do a Kawase approach, you can do far lateral, and those are another depiction of the so-called safe entry zone. So what are the surgicals? And I'd like to divide it into three things. Goals of what you want to do, the strategies, and the tactics. Goals means conceptual reasoning. Strategies mean analytical planning, and tactics means a practical execution. Now, if you're going to remember only one slide of my whole presentation, I would ask you to remember this. I consider that there are 4 steps for each of those 3 things: goals, strategies, and tactics. How do you get there? How do you find the cavernoma? You want to leave no trace of you being there, and you want to resect it completely. So what's the strategy of getting there? Well, you need to understand the surface geometry. What is the strategy to find your cavernoma? You need to understand the depth geometry. How do you cause least morbidity? You need to understand the optimal intraaxial neural pathway that you must take. And how do you resect it completely? Well, you need to understand microsurgical ergonomics. Now, how do we apply some of the tactics to satisfy each of those strategies? Well, you need to, for step 1, you need to know how to position the patient and how to choose your craniotomy. Craniotomy, please remember, is only giving you static exposure, not dynamic exposure. Dynamic exposure comes with step 2. Once you open your cranie, you have to dissect the arachnoid, and then you dynamically move neural structures out of the way. Dynamic retraction doesn't mean you put a spatula and you leave it there. You move your cerebellum temporarily with your sucker. You move the brainstem temporarily with your sucker, and so forth. Navigation is very useful. Preoperative MRI and tractography is very useful. And then the very important issue, where is your entry point? Now you're ready to go to step 3. So once you're there, well, how are we going to create safety? Minimal neural distortion. You want to avoid this idea of what I call cornering, meaning if the lesion is not directly in your axis of view, you will tend to push on eloquent tissue to go around the corner. That's why you have to have step 1 and step 2, making it ready for you in step 3 not to corner. You do want to preserve the main developmental venous anomaly, if there is one. And of course, you're going to do neurophysiological monitoring. Now, you're in there. How do you resect it completely? Evacuate the hematoma if there is one. Maintain, first of all, find it, and then maintain the gliotic plane. If you're running out of room, use your bipolar to shrink some parts of the cavernoma to gain space. If possible, don't do it piecemeal. Now, if it's a large cavernoma, you have to do it piecemeal. But if you keep a small or medium-sized cavernoma all in one piece, you can be sure you got it all out. I often use an endoscope assistance at the end of my resection to put it in the brainstem cavity to make sure I haven't missed anything. And I'll come back to the last point later. Many cavernomas, actually all of them, have a tiny vein draining that whatever blood is in them, blood flow, drains into the DVA. I think if you don't take that small draining vein, they will recur. And I know this from anecdotal experience. I'm not saying take the DVA. I'm saying take the small draining vein that goes into the DVA. So how do we make mistakes, and what are the reasons for some suboptimal management results? I know this is a busy slide, and this is not even the entire list of what I think will be the source of mistakes, but those are the main points I want to make. Number 1, thinking of the table I just showed you, the mistakes can happen in any of those 4 steps at any of the 3 levels: goal, strategy, and tactic. What are particularly common mistakes? Not knowing when not to operate. That's being inappropriately aggressive. Missing the opportunity of when to operate, that means inappropriately conservative. This next one is very important. Anatomy is not equal to pathology. So this issue of safe entry zone is meaningless, almost meaningless, when a lesion is present and distorts the entire anatomy. The safe entry zone concept isn't important anymore. A favorable geometry does not mean favorable physiology. You may remember Spetzler's paper many years ago of the two-point method. Well, we all recognize that this is an incomplete method in planning the right approach. It could be a starting point, but choosing the obvious entry point is not always the safest, meaning particularly in the fourth ventricular floor. And I'll show you examples. Suboptimal execution of steps 1 and step 2 will lead to suboptimal execution of steps 3 and 4. So if step 2 and step 3 tell you different results, for example, step 2 tells you you should do the crani a certain way, step 3 tells you you should do it another way, always compromise in favor of step 3, meaning choose safety instead of convenience or a more direct approach. Other mistakes I've made, missing what I call cauliflower protrusions of the cavernoma stuck through the gliotic plane. That's how you can leave residual lesions. So if you think of a cavernoma like not just a mulberry, but a cauliflower, make sure you get every piece of the cauliflower. I've also learned that those small veins I mentioned, they have to be dissected along with the cavernoma, but not the main large developmental venous anomaly. Otherwise, you will get recurrences. And of course, there is a highly inappropriate use of radiosurgery. I have not seen it work. I know there are about this, and it certainly can create brainstem edema. Next category is what are the surgical principles and essentially the surgical approaches. Well, you will see many publications. They list for you different surgical approaches to different lesions, and they do it also the other way around. If you have the target area, what surgical approach you should use. I'm not going to read those in detail. I'm going to show it to you through case examples. Same thing there. Different areas of the brainstem, anterior, posterior, lateral, and what approach you might use. We all have our biases, and hopefully through my case examples I will show you, you will see my own bias. So probably the largest series published, unless some of our Chinese colleagues may have published more that I'm not aware of, is almost the 400 brainstem cavernomas of Spetzler's career. But even in his hands, half of the people develop a new deficit. New permanent deficits, 35%. Permanent, we're talking, not temporary. Post-op rehemorrhage rate, meaning essentially recurrent or residual lesion in percent, but resolution of some of the pre-op symptoms in about half the patients. And this is, of course, in the hands of a world master. A systematic review by Kalani last year essentially studied 2,500 cases and essentially similar results in experienced hands that have published on those things. Completion rate is quite good at 92%. So if we're going to talk about surgical approaches, we have to pay our dues to our father of neuroanatomy, Al Roten, and I'm going to use from his collection the slides to show some of the common approaches. So there is your terminal cranio-orbitozygomatic, cranio-orbital transsylvian, generally to this area. This is your transsylvian half and half pretemporal plus or minus splitting the tentorium. That gets you nicely here on the midbrain, enterolaterally. There is one of my favorites that I use quite a bit, for this is anterior transpetrous Kawase's approach. That gets you lower into the pons, but not lower than 7th and 8th nerve level. That's a good view of it right there. I love this one too, supracerebellar intentorial. Not so much the midline variant, but the paramedian variant, or the so-called, it's a wrong word, but everybody uses it, the extreme lateral. Essentially, it means go as lateral as you can, like here. That's very, very useful for the collicular area and lateral mesencephalic sulcus. Posterior interhemispheric transtentorial. I put this the way Roten published it, but that's not how I use it, because I don't think that's the best way to do it. I rotate it 90 degrees. I put the patient lateral position, and I don't put a retractor here. I like to use gravity for the hemisphere to fall away from the folds. That's, I think, the best way to do this, with or without a lumbar drain, and that will also get you to this dorsal area, and that's after splitting the tentorium, looking at the collicular plate. Midline suboccipital T-lovelar, excellent for the fourth rhomboid, as you can see, all the way up to the aqueduct and the floor of the fourth vein. Of course, never forget the very simple but very versatile retrosigmoid approach gets you here. The pre-sigmoid subtemporal combined, either retrolab, partial translab, transcochlear, also known as the posterior petrosal approach of Al-Mafti. That is a very powerful approach to give you a different angle to lateral pons, very different from what the retrosigmoid approach gives you. It allows you to go cross-court. And of course, the very useful far lateral approach for the lower pons and enterolateral medulla. So now the rest of the talk is going to case examples of mine, starting from the midbrain, finishing in the medulla. So we're going to go, this is the first example. We're going to do a midbrain, rostral midbrain example. This is a thalamomesencephalic cavernoma. I utilized a Transylvian half and half approach to do this. And by the way, any name you see next to my name are these some of my most excellent fellows that have helped me recently or in the past to edit some of those videos. So this is a 47-year-old male. You can see this cavernoma, thalamomesencephalic. You can see that. I'm going to skip some details because I want to cover as many cases as possible. We're going to go Transylvian, half and half. First, you need a complete Sylvian fissure splitting, and half means you have to identify the anterior choroidal artery, follow it, follow the uncus, the medial temporal lobe. Everything has to be done sharply, mostly. You don't self-retaining retractor till you have finished your complete arachnoidal dissection. Then, if need be, you put a spatula that will hold the exposure. Otherwise, I think it's more than. If the uncus is in the way, it's perfectly fine to resect it, which is what I am doing here. Now, here is SCA and PCA, and my entry point will be right here. Of course, with the help of navigation, you can see the yellow discoloration, and we're doing monitoring, and that's where we're going to enter. You're going to make as small an entry point as possible, and as you will see video after video, all of these resections, once you're there, are the same. They're very standard. You try to keep the gliotic plane. You coagulate suspicious areas. This is the brain stem. This is not the anterior frontal lobe. So you have no luxury of getting lost and entering white matter. I put at the top of the slide things to remind me to tell you. I wanted to show you the draining vein that is not the DVA. That is very important to remove. It's going to come in a minute. There it is. You see, this is a draining vein that some people may say, oh, this is a DVA, you have to save it. No, you don't. If you save vein, the cavernoma will recur. This is very different from saying remove a DVA. You definitely don't want to remove a DVA. There is a vein. You see it? This is a vein draining the cavernoma into a DVA. Don't take the DVA, but take the actual vein. And then when you're finished, here is a cavernoma coming out as much as you can in one piece. And the job is not done until you inspect the walls of the cavity. There is a nice clean wall, and I'm very satisfied that it's gone. There is a wall inspecting everything. As you will see in another case, you can sometimes use an endoscope to look around. And that's at the end. Please notice you have to try to save veins whenever possible. If they're not in your way, just take them. And there is a gross total resection. Oops, sorry. Next example, another rostral midbrain, but this one we're going to use a different approach. It is also thalamomesencephalic cavernoma, and I'm going to use a posterior interhemispheric supracollicular transpineal approach. This is a relatively recent case in October. This is a patient with sudden diplopia, 50-year-old, went elsewhere 4 years ago. They gave her CyberKnife. She gradually worsened 3 years later. Dysarthria, hemiparesis, Parinot syndrome, and failure of inferior gaze, as well as a Parinot. She was then referred to me. So I'll show you her MRI. Here is, again, quite large, thalamomesencephalic, post-radiosurgery. So you could consider a number of approaches. You could certainly think of supracerebellar infratentorial, but I thought the angle would be quite steep. I preferred coming supratentorial interhemispheric. That's, as I said earlier, I put the patient lateral. I believe I use the lumbar drain. You go interhemispheric. Most of the time, you do not need any self-retaining retraction. Now we're going to the edge of the faults, and now what is easy to get confused with these cases is where is the straight sinus. So you can do it visually, or you can use navigation. Here I am marking where the straight sinus is because, of course, we don't want to damage it. Then you cut the tentorium. You cut the tentorium usually not from its edge to its middle, but from the middle to the edge, because there are some venous channels that are easier to control once the middle of it is done. You can certainly do, and I encourage you to put a self-retaining retractor on the faults. That is fine, and that will improve your view. So here I am into the venous angle between Rosenthal and vein of Galen. And of course, we cannot injure those veins. Here is Rosenthal, vein of Galen, and we're going to work between them. And there is a pineal gland. So this surgery, this is actually going through the pineal gland with the help of navigation to get to the lesion. So I stay supracollicular. So that is what we're doing here. We entered, and through the pineal gland, this is a superior colliculus, inferior colliculi, here is inferior colliculi, and of course staying in the gliotic plane. And here is a cavernoma, and again, exact same thing almost for every case until you get a clean surgical cavity. I obviously don't need to say, but it's critical to be very delicate in that plane and try to remove the cavernoma when possible in one piece so you can be sure you haven't left any residual. And that's at the end, and it's a gross total resection, and I thought in retrospect this was the right angle to come to this at. How about a caudal midbrain example using the lateral mesencephalic sulcus? So I'm going to show you a midbrain superior cerebellar pontine. I'm sorry, superior cerebellopontine cavernoma that was operated on elsewhere through a telovelar approach, but they only were able to remove a tiny piece of the cavernoma, was then referred to me, and I utilized a different approach, which is supracerebellar infratentorial, extreme lateral in the concord position. I don't really use much the sitting position, although it certainly has its advantages. So let's see what went on with this case. She's 28-year-old, acute fourth nerve palsy in July and a left hemiparesis. They did this approach elsewhere, but had difficulty seeing on the other side of the DVA. She recovered very well after that surgery and then came to me 6 months after that surgery. She was intact by now. So then a couple of months ago, I took her to surgery and we did this. This was her original bleed, 2019. Here is her original bleed in July 2019. And you will see a DVA. Look at the DVA here. Look at the DVA here, drains into the precentral cerebellar vein. And here it is on angiogram, beautiful DVA. That is totally in the way of doing a telovelar approach. Plus, it's too high. The lesion is too high. So clearly, I don't think this was the correct approach. And that's post-op of that surgery. But she, as I said, she did recover well from that. Look at the DVA, nice view on this MRI right here. So this is how now when she comes to me. Again, I want to show the difference between a midline sagittal view of the cavernoma below the collicular plate and a lateral view. You can see the lateral view tells you what the best approach is. Under the tentorium right here, if you go midline, it's very hard. You'll end up doing what I called cornering. You will not see it well. You have to go laterally. That's what I'm going to do. And that's a video of the case. Thank you to Samir Soor, my current fellow, for editing it. Let me skip through those MRIs that I already showed you. And this is concord position. Tentorium is here. Supracerebellar. Very easy to see the discolored lesion, discoloration on top of the lesion, working through superior cerebellar arteries. You will have very shortly an excellent view of the fourth nerve. Look at the fourth nerve. So I'm going to work essentially below the fourth nerve and probably mostly above the superior cerebellar artery. And there is no need to put a self-retaining retractor. I don't think I've used it in this case, or if I did, it probably was temporarily. As long as you position the patient concord. Now, I must admit, the sitting position gives you even a better view than this, but I believe it's not necessary. So here is the fourth nerve, here is SCA, and we're going to do exactly the same thing. You will, after a while, you'll get bored of these resections, watching the same moves with each cavernoma. It's all the same, sharp dissection, cutting down to the gliotic plane. Here is a lesion coming out one piece and a very nice clean plane. You can see CSF from the aqueduct from the previous resection. Remember, the previous surgeon had gone up, then up the aqueduct. So that's where I communicated to the two surgical profiles. That's near the end, and very clean view of the cavity. Sure, it is completely out when you have a view like this. And that's the post-op. She did beautifully. She really did not turn her head, except she developed a fourth nerve palsy again on a temporary basis. And that's post-op, and that's the angle I took. You can see the benefit of this angle versus the other approach. That's again the DVA that is preserved post-op. Another example of a midbrain coded brain, a mesencephalopontine cavernoma, where I use the Transylvian half and half approach. And I will show you this case mostly to show you the use of the endoscope at the end. I think for speed, I will probably just show you the MRI. You can see quite a large lesion pointing anteriorly in the cerebral peduncle. And we're comparing here which approach to use, subtemporal versus Transylvian versus half and half. And of course, half and half gives you the best of all worlds. That's the view we want, and that's how we want the angle to be. And here is the view, Transylvian. I'm going to skip those portions. Look at SCA. SCA, third nerve is here. SCA is draped on the lesion, which, of course, it's an easier lesion than others because it's reaching the surface. So we will remove it. I'm going to skip. I had to shrink it because I'm against the cerebral peduncle. So I shrunk it with the bipolar. But what I want to show you is at the end, when I was not absolutely sure, I took it all out. Look at the DVA, beautiful DVA on the right. This is the endoscope, 30-degree endoscope showing me a very clean cavity. And here is a post-op imaging. Let's move to the pons. Rostral pons. I'm going to show you a pontomesencephalic cavernoma, pure, simple subtemporal approach. Remember, simple approach first. Don't choose the most complicated approach. If you follow that table I showed earlier, step 1, 2, 3, and 4, you try to end up with the simplest approach. If the simplest approach is not good enough, then you go to a more complicated approach. Now, the problem with this patient, here is her story. She was pregnant 24 weeks and had been given steroids because I didn't want to operate on her during pregnancy. She became Cushingoid. I'm not going to go over the entire history, but she has a strong family history. She's only 36, 4 family members. She knew about her cavernoma for 16 years or so. It was asymptomatic, but she bled twice during 3rd pregnancy. Now, when I say now, I mean 2015. She came to me 23-week pregnant, hemiparetic with a 3rd nerve palsy. Look at the acne, and I can't show you her full Cushingoid features. And look, she was in a wheelchair due to the lesion and the steroids they had put her on in her country. Here is the lesion. Now, here is an important case because you might say, well, the lesion reaches the 4th ventricle. Let's do telovelar. I think this would be a big mistake. She has normal facial nerve function. That is this is a good example of where step 2 and step 3 of my table contradict each other. Step 2 might tell you to do this, but that's not the safest approach. The safest approach is to come from the side. Pure, simple, subtemporal, it doesn't matter how big the lesion is. That is the approach that will give us the widest corridor. So this is a simple cranie. Here is we're doing fetal heart monitoring during surgery. Remember, she's 23, 24 weeks pregnant. It went really well. There it is, gross total resection. Here she is actually improved like day 1 in her hemiparesis, although her 3rd nerve palsy was still unchanged, recovered fully 5 months later. But her hemiparesis within a day was already better.
Can you open your eyes? Follow my finger. Left leg.
I'll move on to another rostral pons case where I'm going to use a subtemporal but a transtentorial addition to the subtemporal approach. This video is very nicely, actually it's published and very nicely narrated by my previous fellow, George Zenonos. So I'm just going to mute just his voice because I cannot show the entire video. But what I want to show you is, this is a lesion. You might, it's very similar to the previous one, but simpler because it has a hematoma. And you can see on coronal, the choice is obvious. We have to do subtemporal with transtentorial. George has included in this publication very nice anatomical detail, cadaveric anatomical detail, explaining why we chose this and so forth. It's too long to go over it today, but to show you that, of course, every case requires analysis in detail and try to decide which approach is better. So the hematoma is here. Should we come through the peduncle or should we come subtemporal through the epitrigeminal entry zone? That's obviously the better approach. You can see the blue sector through the epitrigeminal entry zone, and those are the tracts, more anatomy, and that's a simple approach, very simple. And here is the view, subtemporal with a lumbar drain. You know this anatomy very well. I want to show you cranial nerve 3. I want to show you, I will put a retractor here after I've done the dissection. Here is the vein of Labé being preserved. And I think I will have, with cutting the tentorium, I want to show you a nice view of the artery of Davidoff and Schechter, unless I skipped over, oh, there it is. Artery of Davidoff and Schechter. Here is the fourth nerve. We cut this, so I still believe this is probably, as Dr. R. Day says, might be the source of angionegative subarachnoid hemorrhage. The next trick is to flip the tentorium, and the next trick I learned from Juha Hernesniemi using an aneurysm clip instead of wasting time suturing this. That's a very neat trick to do to hold the tentorium, and then of course you enter the brainstem and the rest is the same. And that's at the end. Make sure we have not hurt vein of Labé, and closing the dura, and there is a post-operative MRI, the post-op day 1. I'll go to another now, upper pontine cavernoma. I want to show you, the only reason to show this case is you can work between veins. Please, please, when you can, preserve veins on your way to cavernomas in the Sylvian fissure. I don't have the imaging to show you, but the only reason is to show you this. You might be tempted, as you're splitting the Sylvian fissure, to cut those bridging veins. There is absolutely no need to. You can work in the triangles between them, and here I am meticulously lengthening the veins so I can actually work between them. I don't want to lose vein if I don't have to. And then we're entering the pons and taking the cavernoma out, and I don't need to show you that. But here's at the end. Work through the veins. A vein is a terrible thing to lose. Now, of course, we get away with it many times, but if it's unnecessary to remove it, to sacrifice it, don't. Another caudal pons, lower pons cavernoma, where I use the Kawase approach. As I said earlier, I love this approach for the enterolateral pons, what I call the second quarter behind the clivus, counting from the top. It's perfect for this area. Many times the retrosigmoid approach does not give you the angle you need. This is a familial cavernoma case. I will show you how this cavernoma grew over time. And this is tractography telling me that I can get to it from a Kawase approach. The fibers were medial. For Kawase approach, I like to use a question mark incision. And here we are. I'm going to skip the details. Kawase means drilling the anterior petrous ridge, apex. here we are drilling with that nice diamond drill that I like very much. It's very safe. It's curved. And you have to drill behind the 5th nerve and above 7 and 8. And then when you've done all the drilling, then you cut the tentorium. Here is trigeminal nerve. And if you haven't drilled enough, you drill some more. And then we enter the pons. The view I have, I couldn't have gotten with any other approach. I am looking straight down the barrel of the cavernoma, and I wouldn't have gotten this with a retrosigmoid or any other approach. Here is the lesion coming out essentially one piece, and here is the surgical cavity. And of course, it's a bigger approach, so we have to put fat to prevent CSF leak. From the air cells, we saved hearing, and here is a fat, and here she is immediately post-op and moving everything, and that's, I think, 6 weeks later. I'll move to another caudal pons case, a lower pontine cavernoma, where I'm using, again, one of the most useful approaches, the far lateral approach. Again, this is a video edited by my former fellow, George Zenonos, who's in Pittsburgh now, and a far lateral approach to a lower pontine cavernoma. It's also published. Here is the lesion. Why? Look at the DVA. Now, why far lateral? Well, look how low it is. It comes out of the lower pons. Far lateral is the perfect angle for this, much better than retrosigmoid, because it will allow us to enter the portion that is most superficial. And here we are analyzing the anatomy of where the lesion is, the tracts, very similar to the other video. So here are our choices. We can enter from here. We could even consider posterior petrosal approach, but it's not necessary. This arrow is the far lateral approach. And in this, I like to do the far lateral with a hockey stick incision. You probably are familiar with this, but I want to show you the view that you get. So above 9 and 10, below 7 and 8, 6 nerve is medial to you. And of course, navigation is very helpful, but you can recognize where you are with the normal anatomy of the various structures. And I'm choosing my entry point. Please dissect the arachnoid very meticulously. Oh, here is cranial nerve number 6. That's medial to us. You can work in the various triangles between the nerves. Here we are using navigation, and you can see the discolored pons. Straightforward. All you have to do is enter right there, and there is hematoma. But I hope you can appreciate, I know it's not in 3D the way you're looking at it, but I hope you can appreciate that the caudocranial angle that I'm using with the far lateral is what makes this resection easier. It would have been a very different view from a retrosigmoid. You cannot look posteriorly enough with the retrosigmoid. Even if you do the so-called low subtonsillar retrosigmoid, you still won't have this view that you'd only get when you remove half of arch of C1. And that's when we close at the end. And he did really well. And I can't remember if there is a text of how he did at the end. No, it's not in the video. Another caudal pons case, again, far lateral approach. I can probably, yes, the reason I'm showing this is to show how the far lateral approach allows a caudocranial ergonomic direction that is not allowed with the retrosigmoid approach. You can see the lesion, lower pons, very similar to the last case, but even more dramatic. The view you have from below up, from caudal to cranial. Again, this is where we're going to enter, below 7 and 8, above 9, lateral to 6, medial to 7 and 8. Here is trigeminal nerve. I'm just dissecting. I don't need to be up here. This is a beautiful view of the 6th nerve. We're going to enter lower pons here. excellent view of the sixth nerve, making sure I choose the least damaging entry point. And I decided that this is going to be right here. That's where we make our initial entry. And of course, the hole always ends up being larger than what you start with by the time you dissect. But it's critical to put it at the epicenter of where you want to be. And same thing, repeat, cavernoma resection, looking for DVAs. And here is at the end. And she did, again, extremely well. Here is post-op. That was a view at surgery. Actually, this is her post-op day 2. This is her 6 weeks later, completely intact. One final, I think I have 2 more quick examples. I see that I have 4 more minutes. I will finish 2 cases in the 4 minutes. This is to show a case that had been operated elsewhere, telovelar, with a residual tumor, cavernoma, and it regrew. And I operated on it 5 years later, recently, through a far lateral approach. I'm going to skip the history because of the time, but this is how she was. She's 27. She was actually 22 at the time, I believe. Here is a small lesion. She was almost asymptomatic. It grew. She went at another institution where she was operated like this. See, the problem with this is there is functional brain tissue. Here, I honestly would not have operated at this stage. I would have waited till it's bigger. So this was her surgery. She had a rough post-op course, and there clearly was a residual, and the residual regrew over time, 2017, 2018, and now she presented to me in, I believe, August or September last year with this larger lesion. She had had a facial palsy before. She had had facial reanimation. This is case sequences across her MRI to help us understand where the lesion is from midbrain all the way down to the medulla. The different colors are for the midbrain, pons, and medulla. So she still had a facial palsy grade 3/6. I did not want to go back through the 4th ventricle, which is why I chose left far lateral approach. And look at the very nice view with the navigation at surgery, the very excellent angle as opposed to the telovelar in this case. This was now, of course, a better angle. That's a DVA at the end of the resection. After resecting the lesion, here is again far lateral approach. And post-op day 1, look at the codocranial angle. This is what you get when you do a far lateral approach that you cannot get with anything else. From below, looking up. Here is her very nice DVA post-op preserved. I think I'm going to skip, this is an example, very simple, of telovelar suprafacial approach. Maybe what I'll show is just how to map the floor of the 4th ventricle. Here is the lesion, reaches the surface. I cannot get to this from laterally. It's too deep. I have to go through the 4th ventricle. But what I really want to show you is you have to map the facial colliculus to decide, do you go suprafascial in your entry point or infrafascial? And you will see the facial colliculus. I am mapping it with stimulator, and I'm marking it with a pen so I don't lose it. So that's facial colliculus and facial nucleus. That this is a no-fly zone. You cannot get in here or you will give the patient a complete facial palsy. So I went above that. But still, even though I was above that, I did give the patient severe nerve palsy that lasted many months and didn't fully recover. So whenever I can avoid operating through the floor of the 4th ventricle, I really try to do that, even though we talk about so-called safe entry zones. And the post-op, yeah, here is a post-op MRI. I took it all out, but it came at the cost of the facial nerve palsy. I will skip this one, and I'll finish with the medulla. This is another similar case. Medulla case, one medulla case, telovelar approach. We'll skip. She bled twice. She's 35 years old. And just to show you what it looks like at surgery, the MRI is lower caudal medulla. You can see it there on your bottom left. You can see it growing over time. And here is the view at surgery. You know, it's so much easier when they're protruding like this, but you can still cause damage by staying close to the cavernoma. And I'm gonna skip all that, and post-op MRI was a gross total dissection right here. And I think I'm done. I'm putting this as a list of some references from my place, if anybody wants to look at them later. Thank you very much. I think I'm exactly 1 hour. Thank you.